So thanks everybody for coming in live. It's great to have you here. We'll kick straight off because we usually run out of time in these sessions. So good morning and a very warm welcome to this graded motor imagery in the clinic. My name is Joanna Taylor and I am Director of NOI in Europe, and I'm joined this morning by my very good friend and Principal NOI teacher, Tim Beams. Morning, Tim. Tim has been a NOI teacher for over 15 years. He has taught many GMI courses to many clinicians all over the world. He is an active clinician himself, specialising in complex and persistent pain, and he's also founder of an organisation called Pub Scientifique, which is an online platform for clinicians to learn about the latest developments in clinical practice and pain research directly from researchers and pain specialists. It's a really fun place to go and check out, and they have a really good podcast. And I think it's been Melanie Knoll just been released this week, Tim. So maybe if you could just drop the link to the podcast and to the website in the chat, and then if anybody's interested in checking out what you do in addition to NOI teaching, then they can go and have a look over there. Tim is also co-author of the Graded Motor Imagery Handbook with David Butler and Lorimer Moseley. We were just talking about that before we came on, and that book is now, that was about 10 years ago, Tim, is that right, that book was published?
Yeah.
Yeah, so goodness, I don't know where the time goes, but yeah, it's a brilliant book. So we'll be talking about that a little bit today in the session. So these sessions that we're going to be presenting this morning are all about giving you both an introduction to GMI. If you haven't been on a course, then it'll act as a way to sort of understand what it's all about, what the approach is all about, who it can help, how you can use it as a clinician. And if you have been on a graded motor imagery course, most likely with Tim, then this will act as a refresher to go over some of the things that you learned during the course. So just a couple of things before we actually kick off. Tim's going to be talking for about 20 minutes. If you have any questions, please put them in the Q&A or the chat, and we'll get to as many of them as we can. If you want to watch the recording of this session, you can access it in our YouTube channel, which I will drop the link to during the presentation. So please do come over and check that out. There's past episodes in there. So there's a whole library of these live sessions about graded motor imagery and explain pain. So it's a really useful resource. So Tim, today we are talking about an introduction to graded motor imagery. So perhaps you could kick us off by telling us a little bit about what GMI is and what it means to you. Thank you.
Yeah. Well, we always abbreviated it because it just felt easier. GMI, graded motor imagery. So, well, it's if you break it down, it sort of tells you exactly what it is. It's a graded approach, and that actually is quite a key part of what the treatment is. So we'll discuss that in a second. Motor imagery, again, it sort of gives us a flavor of what that might be. So in essence, it's a brain-based training technique that includes a graded approach, and it's typically in three components or three steps, three stages. I rather the phrase components, because steps suggest that you do one step, then another step, then another step, and it's always going to be in that order, although order might be important. But there are three steps. The first step is a left-right judgment task. So basically it's getting someone to identify whether they see an image of a left or a right body part. Another phrase for that would be implicit motor imagery. Implicit meaning you're doing it as quick as you can, so you don't know you're doing it, or you don't know rather how you're doing it. So it's a conscious evaluation. So you're trying to evaluate something out of your awareness, in other words, very quickly. The way that your brain works doing that is very different from doing it knowingly. So within your awareness, or explicitly, which is the second component. So explicit motor imagery will all have done things like this. I mean, you'll have done the implicit stuff that you didn't know you're doing it.
Yeah.
but explicit motor imagery is that you are running some sort of imagined movement. So you're imagining yourself doing a movement, you're imagining the feel of that movement as well, and perhaps you're also seeing yourself as if you are doing that movement as well. So they're sort of two elements of imagery. The third component is probably the most well-known one, just because you see things like the use of mirrors in a house, or so you see videos online as well of someone using mirrors and as a way of rehabbing them. So mirror therapy typically was, I should have queued this up, I've got a mirror, I've had my mirror somewhere, not right next to me, but you typically have a mirror to the side of you and you're looking at your reflection as if, so you're seeing, in this case, I would be looking at a reflection of my hand on this side, but I'm seeing it as if I'm seeing the hand on the other side. So it's given me the sense that I have an intact body part, if you want, where that that it's a reflection, but the way that we process and understand it is as if you are seeing it for real, even if it wasn't there. So yeah, three components. And they're typically performed in a stepwise progression. So you start with the left-right judgments, you move on to the motor imagery, and then you follow that with mirror therapy. Now that's how things have been used in a protocolized approach. So that's, if we look back 20 years ago at Lorimer's original protocol, that's how it was performed. And I feel like I'm talking too much now, but but the protocol was a 6-week protocol. So 2 weeks of one, 2 weeks of another, 2 weeks of another. We can talk about the merits of those later. So you finish one, you started the other, you finish that, and then you finish the other, and then who knows where you go after that.
Yeah. Okay, thank you, Tim. So one of the things that I was quite surprised about actually was the scope for which GMI, the components of GMI, or the whole approach can be used. So could you just give us a little talk through about sort of who you might be able to use that with in the clinic, and if you maybe have a couple of little examples in there, that would be super.
Yeah, so well, it was originally designed with complex pain in mind. So where do you go if all movement is painful? I mean, that was a sort of, I think, a simple question to have in your mind. So one thing that you can do, understanding the role of the brain in pain, is that you could imagine movement. So it sort of gives us a way of, it gives us room. When things have been so difficult, and we've all had patients like this, you're thinking, oh, where do I go now? What can I offer? And a typical sort of rehabilitation approach is that you gradually just, increase the amount of movement that someone does in perhaps a paced way. So a lot of people have heard of GMI relating to complex regional pain syndrome, and Lorimer's original choice there was, it was just a complex pain problem, often involved, a part of a diagnostic workup of it is that it's painfully restricted movement. So if we could offer something to that group, theoretically at least, we should be able to offer something to everybody in pain. So there's lots of research now in CRPS. Phantom limb pain would be another one as well, a pain condition. And then there are movement disorders like dystonias, where it could be effective as well. And we're starting to gather evidence in a number of other areas. so looking at people post fracture or post injury or post operation, and particularly people who would be immobilized typically for a period of time. So if you come out of a cast, I don't know if you have had that, Joe, but
No.
if you've been unable to move for a period of time, it's very, very typical. Movement is stiff, painful, the doesn't look great. You might have a bit of discoloration. The skin appearance isn't great. You might have a bit of hair growth where you didn't have it before, and things. So those, there is a risk of people developing ongoing problems if that is poorly managed at the time. So people are starting to design trials. I know there's one pretty much finished in Australia, and we're just about to start one in the UK and Europe as well, where we're looking at acute injuries and seeing whether we can offer something there. Did I answer your question?
Yeah, you did answer the question, and you actually went on to sort of start to move into the next question again. So just given that you were, I have seen your question, Mark, and I'm going to come to that in just a second. But given that you were there, really, Tim, right from the beginning, and co-author of the handbook with Lorimer and David, have you been surprised at how its GMI has evolved from being something that was really looking at a complex syndrome through to now you're talking about using it in acute situations? Is that something that you expected to happen?
Not really. I'm not surprised. No, not really, because athletes use motor imagery. I always think of Usain Bolt or divers on the, just about to do a dive from a high board. They mentally imagine themselves going through the task, and that's an important part of the process. So, high level athletes using elements of this. In fact, I had a conversation about this the other day, because a good friend of mine, I haven't seen her for ages, but she used to work with the English netball team. And now she works with high-level athletes, international athletes. And we were designing something way back, like 50, I don't know whether it was 15 years ago, definitely 10 or 12 years ago, where we were getting netballers to practice the left-right judgment and then have to catch a ball. And she like they didn't necessarily have a problem, and it was a performance-based thing that we were doing. And she was telling me at the time, she was like, "Hey, it was a really effective way of building skills." If anything, I would say we've been a bit slow. Like there's a lot still to know and understand, but what GMI did for me is it opened up my creativity can start coming out, and I think that there's an awful lot more we could do, but it came out at a time when it's ridiculous now to think of it, actually, because we're so sort of, as I say, brain-based training program. I feel that sounds ancient, like we've moved on from that. But at the time, people were like, the brain, what are you talking about? Why should I be thinking about the brain in here? Because my pain is in my body, and absolutely it is. But it was at a time when people were really struggling to actually to sort of about face and say, what, brain and body are connected, and actually we need to understand the two together.
We're almost at the stage now where you can't believe that we ever thought any differently. And I think that GMI it is just the perfect sort of approach that gives it underpins that approach, doesn't it, and gives people the evidence to support what they've been doing intuitively for a long time.
It does. I'm just about to record a little video on a book I've just read, but it makes me reminds me of, like, we were in a meeting in Hamburg. I was in this meeting in Hamburg. I remember it really well because I was staying in a hotel with Morton Ho, and he's like, "Oh, it's okay, I've organised a room," And he's like, "You're okay staying with me, aren't you? We're sleeping in the same room." I'm like, "Yeah, yeah, yeah, that's fine." Anyway, it turns out to be the hotel used as like the local brothel. So then,
Only you and Mawson, Tim.
yeah. So sirs, you're staying together, are you? Yes. You're looking for the hour or for the whole night? And it was so it was quite funny. But I remember being in the meeting and we were like, do we want to call it GMI still? Because it was so early days.
Mm,
And we were just throwing out like crazy um, titles for it. And one of them I always remember was "Sizzle the Synapses," and actually, it was a pretty
you weren't far wrong there, were you?
yeah. And so the book I'm actually going to review is a lot of it is about how neuroinflammation affects the synapses and
Mm,
synaptic health and pruning and actually now that is like starting to be better understood and known about, and this was way before that. I think if anybody here is working in rehabilitation, we don't have an invasive procedure. We don't have tools like transcranial magnetic stimulation and things necessarily, but we do have GMI, and everybody can do GMI. And there's
mm,
absolute credibility, plausibility that we are going to have a very real effect at the level of the synapse. And I think that is quite powerful.
mm. Yeah, I couldn't agree more, Tim. It amazes me when we talk about when you start getting on in a groove talking about this, about the graded motor imagery approach. It kind of amazes me that just how broad it is, and just how it can help in so many clinical scenarios. Right, I've just got to come back because Mark's question here, which is a brilliant question, and it was completely appropriate. We see in the clinic, we see in clinic people with severe complex regional syndrome. In some cases, even early stages of GMI are not possible. For example, left and right discrimination causes pain, increase on the patient's affected limb. What would you suggest in these cases?
Uh, Thanks for the question, Mark. I've seen these people as well, not in early stages, but they be persistent pain when they get to me. And the way that it was protocolized before, which is problematic for me, is that it was delivered only on the affected body part. So, say you have CRPS affecting your hand, you were guessing images relating to your hand. And we see that there is a sort of, if you want, there's this two subsets, but even that is a bit crude, where some people have a heightened attention to the bodily part, some people have an altered, a shifted attention and awareness of the bodily part, maybe away from, if you want, that body part. That again is a bit crude. But if you'll have people, let's take the group where they've already got heightened awareness. What you're doing with that task is you're training them to have a heightened awareness of it. So you are just going to make them worse. And that still is not unpicked in the literature. In fact, there's a couple of studies fairly recently that I'd love to unpick with the groups that have done it, and because there are people who clearly have
Do you
a
do this in the course, Tim? Is this
yeah,
is
yeah.
do you,
Well,
yeah, yeah, yeah.
we'll talk
Okay,
about it
just
in the
checking.
course. Yeah.
Yeah.
Um, because some people do get worse. A lot of people get better, and on average, we see that when you group people together, the average is that people improve. But there are obviously people who get worse, and they're not outliers. I think that there is a typical presentation, a phenotypic, presentation, an
Mm,
appearance of someone, and an example. So Mark, you're absolutely right. That's absolutely possible. My suggestion to you isn't just dismiss GMI as an approach, but understand whether you have a similar presentation. Let's say it's their hands. Do they have the same effect on their feet? And what we see with CRPS, for instance, is we have whole-sided changes, and it might be important to start working as far away from the affected body part as possible. I've got a couple of people in my mind. I mean, I've written about one of them in the book, but where the pain was so severe on the affected leg that we were doing techniques relating to her face, neck, hands way before we got close to her feet.
Mm. Amazing
question. Yeah.
yeah, I think
And
so.
GMI should never be a standalone treatment. So there will be elements of let's call it, again, I'm being totally crude, but threat. If threat remains, for whatever that means, maybe it's threat of, what's to come, or what pain means, or whatever. So we need to understand that, and where we can, just bring that level of threat down. And that means education, perhaps, and understanding what they're specifically experiencing, but it also might mean working on techniques that lower your saliency, your threat detection systems as well.
Brilliant, thanks, Tim. We do always end up getting into the sort of nuts and bolts when we talk about GMI. I hope that you can sort of see that we've only got 20 minutes here, and we can sort of we can skirt over the the tiny bit of what is covered in the course, and Tim will obviously go into a huge amount of detail in the course about all these things that we're just touching on. So Jackie, we've seen your comment about the paper. We will absolutely drop that into the show notes when we upload this to YouTube. So make sure you have you've checked out this recording on YouTube.
It's not been published yet.
Oh, has it not? Oh, sorry. So you can't do that. Okay. And
we'll get it out there, right?
So will we be able to access that, Tim, or not? That paper.
When it's published, we can get hold of it. Yeah.
Okay. Okay. Great. So let's make a mental note of that. So if Wendy, if you're in the NOI clinical discussion group, the Facebook group, we'll pop it in there. And if you're not in there, then I'm just going to drop the link into the chat now, and then please come and join it. It's a really good group, and it's where we can share things like that. So
pelvic pain
Tim,
is a bit different. I've seen the question. Yeah. It is a bit different, and there are people like Sandy Hilton who've been thinking about that as a sort of as a puzzle, if you want. And so use of imagery is absolutely an awesome thing for pelvic pain. I mean, painful sex, for instance, or painful sitting. It depends on how it affects someone. So there's a number of things that you can do there that include exposure principles. And then Sandy, for instance, has used the mirror to get people familiar with both looking at the pelvis, the genitalia, and also the sense of touch as well in that areas, and normalizing sense of touch. So you would use it a bit differently. There is not a current left-right judgment for axial body parts, so we have something for the neck, but not so much the face. People have tried to develop it. The breasts and the pelvis as well. So yeah, there are obviously certain areas of the body where we would have to be a bit more creative.
Great, thanks, Tim. And have we seen the other message there in the chat? I've just dropped in the link to Tim's next GMI course. If you want to go and if you are interested, it's online. You can access it from anywhere in the world, and it is absolutely superb, that course, isn't it? We get brilliant reviews from people who have done that.
You asking me to?
There's Berku from Turkey was asking a question about I see you do not draw so much attention to this point in the articles published later in your speeches. Has there been a change in the implementation of this phase related to the left-right discrimination stage?
So when you're guessing your left and the right, in other words, I think, Berku, you're saying you shouldn't move your body. Well, that's true if it's possible. Although, let's say someone has foot pain and they're struggling to verbalize, you could get them to wave their hand on the side of the foot that they see. So you could get the body moving, but yeah, if you're trying to get this implicit element, then we want to try and do it out of awareness, as quick as possible. And when we start getting the body involved in the guessing process, then it's more likely to be an explicit task. So it just depends on what you're aiming to do. So are you trying to get the sort of uncorrupted data of an implicit task, in which case aim to sort of account for or limit bodily movement? If you see that as part of the sort of rehab and graded exposure approach, then no worries.
Okay, cool. So I think we're just gonna pull this to sort of a bit of a conclusion. I think definitely what I've taken away again, Tim, is the flexibility of the graded motor imagery approach and how it has changed so much in the last 10 years, and its breadth of application is just so much wider than we would have maybe seen straight away, although we probably should have seen it. But
it's worth saying you do need some tools. You do need some tools.
Yeah.
But when we started doing it, I mean, I can remember working in my clinic in London, and I cut out pictures from a magazine and laminated them, and you know that we didn't have apps at that stage, and I remember we taught a load of courses in Australia, and we went to the hardware store and bought a load of mirrors and just backed them onto some plywood. And so it's absolutely possible to, and that's what my patients do now actually, is they just find their own equipment to suit them. So I know you said, could I tell you about some examples, but I have one lady where she is a wheelchair user, but she's built the mirror so that she can wheel her chair into the mirror. So there's and then she can use it as and when she wants, so regularly in the day. So there's definitely ways that we can provide for ourselves. So.
Yeah, that's brilliant. Thanks, Tim. So we're just going to wrap up now. Tim does have we run the graded motor imagery course twice a year. There was one in June, and we tend to run it at the end of November, beginning of December. So he has got a course coming up. I've dropped the link in the chat. It'll also be in the show notes if you want to check this out on YouTube, if you're watching on replay. So Tim, could you just tell us a little bit about the course, if anybody is interested in finding out a whole lot more about graded motor imagery?
It's December, actually, mid-December.
Is it December?
What do I do in the course? What do you want to know?
Just maybe the kind of people that come and what they go away with.
Look, we are scratching the surface here, aren't we? So we'll go into some science and philosophy. You'll hear about some of my patients. I'll show you a couple of videos of people doing stuff so that it's not a nebulous topic. Online, we can actually you can do it yourself. So it's an important part of the process is to feel what it's like, have a go at it. And then you are in a much better place when you want to offer it to other patients as well. So and then the beauty of any course is being there with other people, so hearing their experiences and the types of people they work with and how they approach it as well. So that's what I would say you can get from a course. Look, courses are just invaluable, aren't they? Like I get something every course I teach because I love hearing what people are doing.
Yeah, absolutely. And like we were saying earlier, it's sort of this course will it reinforces things that you've probably been dabbling with already, but it just pulls it all together in a way that you can use and trust fully. So thanks, Tim. Thank you, everybody, once again for joining live. It's always wonderful to have your questions and for your interest, and keep your eyes and ears open because we'll be coming back with another live in a couple of weeks' time. We're not doing anything next week, but the week after, I believe we've got another live. So watch out. We'll send you a notice by email, and it'll be announced in the NOI clinical discussion group. So thanks very much. And as always, great to have a live audience. Thank you so much. Take care, everyone. Enjoy the rest of your day.
See ya.